For a case of a pediatric seizure, using our mnemonic old carts, we'll note the onset, or when did your child's seizure start. For the location, we'd like to know what part of the body was involved. For the duration, since it is unlikely to be constantly seizing, we'll ask how intermittent are your child's seizures. That is, how long is a typical seizure lasting for, and how many seizures has your child been having per day. Or if this is a first-time seizure, we'd also state that in our patient note. Next, we'll note the progression. Are your child's seizures appearing to occur more frequently or more severely? Or if there has been no progress or no change in the seizures, we'll state that in our patient note too. To help characterize the seizures, we'll use our technique of pre, present, and post, as we'll see below, and aggravating and alleviating factors. Or if there are no aggravating and alleviating factors, we'll also want to state that to show we've asked. On the pre side, we'd like to know what was your child doing beforehand, and if they experienced any auras or warning signs, such as palpitations, lights, or smells. Presently, during the seizure, we'd like to note how long your child was seizing for, and we'll pay particular attention for the seizure activity, and it's important we ask about these individually because one could occur without the others: shaking, tongue biting, and urination. And in the post-seizure, we're going to ask, and again, it's important in high yield that we ask about these individually because we could have one without the other, for any sensory numbness, motor weakness, or confusion afterwards. In all pediatric patients, instead of a physical exam, we're going to use our mnemonic BITTER to remind us to ask about the birth history, immunizations, developmental history, diet, education, and to reflect with the parent. For all cases, let's order a physical exam, CBC, and serum electrolytes. In a simple febrile seizure, our supporting points include a seizure for the first time and a fever. Our workup and questioning next focuses on identifying the source or cause for the fever. So we're going to reintroduce our stick figure to remind us to start from the head and work our way down to the toes. Starting in the head with meningitis, we'll see a seizure, a headache, stiff neck, petechial rash, decreased oral intake, nausea and vomiting, and if we have any vomiting, we'll be sure to use our mnemonic A, B, and C to write down for our patient note the amount, if there's any blood, and the color, bilious or non-bilious. We'll add to our workup an LP with CSF analysis. In otitis media, we'll see ear pain. It will be alleviated by pulling, and we'll have a history of a recent URI, runny nose, cough, or sore throat, and we'll add an otoscopy. In a URI, we'll have a runny nose and cough, and we'll use our mnemonic A, B, and C, and possibly also a sore throat, and we'll order a respiratory viral panel. In pneumonia, we'll have a cough, and we'll use our mnemonic A, B, and C, shortness of breath, and again, if our patient is young and can't communicate, we'll ask the parent if there was any change in their breathing patterns, such as belly breathing or nasal flaring, and we'll order a pulse oximetry, chest x-ray, and sputum gram stain and culture. In gastroenteritis, we'll see abdominal pain, and again, if the patient is young and can't communicate, we can ask the parent if there's been pointing to their stomach more than normal, nausea, vomiting, or diarrhea, and we'll use our mnemonic A, B, and C, and for the amount, we'll ask the parent if there's been any change to the diapers per day, and we'll order a stool leukocyte, OMP culture, rotavirus assay, and Shiga toxin. In a UTI, we'll see a polyuria, and again, we're going to use our mnemonic A, B, and C for the amount, noting the diapers per day, dysuria, and for a young patient that may not be able to communicate yet, we could ask the parent if they've been crying while they've been going to the bathroom, and we'll order a urinalysis and urine culture. In a viral exanthem, we'll see a skin rash, and our patient will typically be unimmunized when we ask about the immunizations. We'll order viral antibodies or titers. And in bacteremia or sepsis, we'll note a high fever. Our patient too will be unimmunized in their immunization history, and we could note a history of skin cuts or recent falls and daycare attendance, and we'll order blood cultures. In an absence or petit mal seizure, we'll have a seizure, and now it will not be the first occurrence, so there will be multiple reported episodes. The seizures are typically characterized as going to be blank stares. The duration will be seconds, so if it's lasting more than seconds, it's typically not going to be an absence seizure. There will be no loss of body tone and no post-ictal state, and it will be aggravated by hyperventilation, and we could also note a positive family history. We'll order an EEG. And finally, in a generalized tonic-clonic seizure, we'll see a seizure, and again, multiple reported episodes. There will be either shaking, tongue biting, or urination, and we can note the post-ictal state. So it's important we ask again individually about any sensory numbness, motor weakness, and confusion. And if there are none, we'll also want to identify all the negatives too. And we can note a positive family history, and we'll order the EEG.